I'm going to jump into the case, a couple case. I have a case study, and then Dr. Knapp has a case study, if that's okay with everybody. And just kind of an example of how you can use genetic testing to affect change, basically, is my kind of goal, or what I want you to see with this story. So, like I said before, I do a lot of weight loss, and I had a patient in, a 39-year-old female, who had struggled with her weight her entire life, but particularly after the birth of her second child. I don't know if that sounds familiar to anybody in here, but I have definitely heard that a lot from my patients. So current health conditions, not a lot, nothing specifically related, maybe some low back pain. The current diet, though, was pretty good. This person was doing everything. They were eating paleo, they were exercising, she was exercising, and no weight loss whatsoever. She was exercising 5 to 7 days a week, 30 minutes at least, eating paleo, no medications, very healthy. Nothing, no budge, absolutely. And when I did the physical exam, and it was unremarkable for anything. So I was kind of at a loss, These are a lot of the tricks that I use anyways, is decrease those carbs, get them off the pro-inflammatory foods. Sometimes if you take out a food allergen, I don't know if you've ever noticed this, but a patient can lose like 10 pounds in a week. And they're like, it's a miracle. And I'm like, it's just you're reacting to dairy. But yes, it is. And then that's so awesome too, because then that motivates them. When they see weight loss, it motivates them to keep going. It's really hard to get a patient to keep going when they're not seeing weight loss after doing something for 10 months, right? So I ordered some routine blood work. I looked at their CBC, their metabolic panel, tested her thyroid levels. That's always my first guess there. And then I did some genetic testing for weight management and nutritional deficiencies. And the results were, of her regular lab work were pretty unremarkable. Maybe she had a slightly high MCV. So she was, the little red blood cells are a little bit too big. But her TSH levels and thyroid levels were all normal. And her fasting blood sugar levels were normal. So I wasn't really worried about diabetes or thyroid disease with this patient. Oh, my apologies. So the results of the genetic testing came back. And she had a copy of FTO, ADRB2, and SH2B1. And so I started to kind of put together this picture of this patient that was hungry a lot. FTO, as if you guys remember, that's the hunger. And then SH2B1 is hunger plus blood sugar levels issues. So when I started talking to her about that, she did report some issues with hypoglycemia, but never anything on her labs. And the sluggish metabolism. Then that picture started to come clearer. This is going to be somebody who's going to be dieting with not a lot of success. So my first goal was to control her appetite and help her with that. And when I asked her about how her success was on low-calorie diets, she was incapable of doing them. They were miserable for her. Maybe, she had a strong fortitude, but getting into them, a couple weeks into them, and she just wanted to die. It was like no quality of life. And as we've talked about it, if you can't find a diet plan for somebody that they can do long-term, then it's worthless. They'll lose weight, sure, and then the weight will come back up, and then that'll hurt even more just in their soul, if anybody's ever struggled with their weight. The nutritional deficiency panel also revealed issues with vitamin D deficiency and a risk for low B12. And I was already seeing that in her lab work with her bigger red blood cells. And her serum, when I retested her serum vitamin D levels, they were low. So right there, I was like, okay, I can fix that. I can affect that. I can increase her B12. I can increase her vitamin D. But I didn't really think that was addressing the issues with the weight control specifically. So my treatment plan was I did intermittent fasting with this patient. I said every day for 8 hours out of the day, eat your good diet, exercise, continue that, but just eat during that 8-hour period. And you go to town. You know what I mean? Like eat so you feel full. And she did. And she said not only did she start losing weight immediately and dropped a lot of weight for her, but the number one thing that she reported back to me was that this is the easiest diet she'd ever done because she was able to feel full. She was able to eat till she felt full. because it was easy for her to control what she ate. What was struggling for her was to control how much she ate. So you give her a window like that, and it was a good mix. It was a good fit for her genetically. Now, does that work with other patients? No. There was another patient that I had that was on it, and he said he gained weight with doing intermittent fasting. But when he changed his diet, what he ate specifically, to be more like her, then he dropped lots of weight. So
you can't just eat only cake in that 8 hours?
Yes. I've seen patients try that, do intermittent fasting where they eat nothing but high calorie foods for 8 hours a day, and surprisingly it doesn't work. You can still put on weight that way. I know, it's amazing. So you still have to have some type of like healthy diet and exercise regime, but when you're telling a patient who's been, eating perfectly for 10 months and exercising, that if they just tweak it a little bit and suddenly she lost, I believe, like 23 pounds in a 6 month or 4 month follow-up visit. And that was a lot for this patient. So her starting weight was 180. I don't know if I put that in there or not, but her starting weight was 180. So, and she's about 5'8". So it wasn't like she was super overweight either. So that's another thing, that sometimes if somebody is larger, they can lose a lot of weight very quickly. And then her MCV was better with the B12, and her vitamin D levels came up. Her mood and energy level increased, but I think a lot of that had to do with just feeling proud. Yeah, like you finally accomplished this thing, you've worked for it. It's huge for your psyche. If you've ever dealt with weight loss, there's a lot of mental, emotional component to it. So, all right.
So this is a 65-year-old patient. I know I mostly deal with kids, but I also deal with, I have a lot of families that then will just jump on board with me. So this is a 65-year-old woman, and she was not the healthiest woman around. Family history of osteopenia, personal history of osteopenia, and inability to get her D levels into an optimal value. History of hypertension, hypercholesterolemia, struggling to lose weight since, she was in her 40s, I think, when she started to really gain weight and then was unable to lose it. Past medical history, so she has a history of oral herpes, as long as she can remember. Pneumothorax at 35, asthma, history of depression, had been medicated on a couple of different antidepressants, currently managing unmedicated. Full hysterectomy in 2015 because of fibroids and spotting. History of a DVT following a flight. She was managed on Xarelto temporarily. 15-year history of smoking half a pack a day. She'd quit quite a long time ago, though. And then she had a pretty sad diet. She wasn't eating fast food all the time, but mostly packaged, very, very little fresh fruit and vegetables, almost no water. And she thought she was doing pretty good. So I wanted to keep her morale up and also gently teach her the ways of a little bit of a healthier diet there. Her DEXA was 1.5, or negative 1.5, excuse me. So family history of osteoporosis and colon cancer, father of alcoholism, high cholesterol, hypertension, emphysema, mental health stuff going on, lupus, bipolar, and osteoporosis in her sister. Her social history, she had 2 children and 5 miscarriages when she was younger. Those were all under the age of 35. She was a school nurse for 35 years and was working on doing Qigong regularly and walking, but not particularly active. Currently on Gemfibrozil, 600 milligrams twice a day for the past 3 months. Lopressor to manage her hypertension. Albuterol inhaler is needed. Supralacine plus is needed for oral herpes onset. And fish oil 1,000 milligrams a day. Diet was coffee with whole milk in the morning. So this was a patient where she was like, oh, I'm intermittent fasting. ish, right? Yogurt or a cheese stick at 11, a couple of almonds or a few crackers at 2 p.m. And then in the evening, she would eat out, right? So burgers, French fries, or she'd do Trader Joe's foods. And then often she would find herself falling off the intermittent fasting wagon, and she was a nighttime snacker where she'd eat like an entire box of Wheat Thins, you know? And she was honest with me about that. So I don't know. Does that mean that it was even worse or that she was just forthcoming? I'm not sure. A little bit of coffee, 16 ounces a day, some herbal tea, lots of seltzer, but not a lot of water. In terms of her mood, I'm so sorry, excuse me. Her only joy was from spending time with her grandkids, but generally a very negative outlook, really low motivation, common agitation and irritability. Her PHQ-9 was a 12 out of 27, so moderate depression. Sleep was interrupted, waking up frequently, a lot of rumination in the nighttime, and I don't think I have it in there. She would use Xanax for sleep as needed, and she often would sleep really late into the day in retirement. This patient's 5'3", 178 pounds, on medication, 160/70 was her blood pressure, pulse of 74, and 20 breaths per minute. Labs when she came in, cholesterol is 234, so not terrible, but granted she's on the gemfibrozil, and her LDL is 140, non-HDL 157, and her HDL looks good, right? 77. That's not too high, not too low. Vitamin D 28, so not super deficient, but considering she's supplementing or was trying to supplement, it's not particularly high. In terms of her overall CBC, things weren't particularly out of whack, but these eosinophils were quite high. Allergic presentation, maybe something underlying we're missing, perhaps a histamine intolerance. Overall, her glucose was okay, her fasting glucose, and overall the CMP looked okay except for these elevated liver enzymes, and she had been working on potentially having issues with liver. So, I gave her dietary recommendations. We did some genetic testing. She has quite a few polymorphisms. So for weight, FTO and DRD2, so this makes me think of part of that nighttime eat a whole box of crackers type situation. Dietary fat sources and utilization were a little bit interfered with, as well as the satiation and the leptin insulin imbalances. So we did, I gave her solid direction in terms of her intermittent fasting. We started mindful eating, sit down, take a breath, chew your food, be grateful for your food instead of this sort of mindless snacking in front of the TV, because we find ourselves going really overboard in those cases. Chewing thoroughly, fluids, we avoided fluids with meals to support her digestive enzymes. Blood sugar balanced diet, so I made a couple of changes. We added in collagen powder to her morning coffee. We tried to increase protein, increase fiber, and added in some fiber-rich foods, so it's not like just, take your fiber powder and then cinnamon in the coffee or muesli daily, and then trying to add in garlic. We did some targeted supplements like chromium and gymnema to manage insulin and blood sugar. And then this is her cardiac panel. 9p21 is heterozygous, NOS is heterozygous, her MTHFRs, compound heterozygous, AGT heterozygous, and ApoE, E3, E4, not so hot. So that was a good one to inspire her, right? She's got some significant risk factors here. Compound heterozygous and MTHFR and ApoE3, E4, that's ApoE4. So her risk of cardiovascular disease and Alzheimer's are high, and those are things she's concerned with. She's 65. She's not a young chicken. She's, lived a good amount of life, and memory was something she worried about. So we worked on folate-rich foods. I really wanted this patient to eat more leafy greens. We added in the fiber, the water. We did some pulsing of 5-methylene tetrahydrofolate and a high B complex. We increased her essential fatty acids. specifically EPA, DHA. And then we increased exercise. And this is that chart I was talking about that talks about patient enzyme activity. This is a compound heterozygous here. Nutrition, we had all sorts of issues coming up here. She had homozygous GC, CYP2R1, and food2. So microbiome, B12 deficiency is something she's prone to. And then a whole bunch of heterozygous vitamin D receptor, iron, and vitamin A deficiencies. And this is a patient where night vision was really quite a big issue. So due to the previous D3 supplementation failure, we started calcitriol and we titrated up to 1.25 micrograms for 3 months. We scheduled an iron panel and ferritin. I didn't rush it because of the normal CBC. We started retinol palmitate, 20,000 IUs for 3 months. And then we would do serum testing. Not the most reliable, but better than nothing. Oh yeah, here you go. Poor night vision, dry eyes, dry skin, and hair. And then bi-monthly B12 injections, as well as her B complex. Methylation panel, we already saw the compound heterozygous. Her NOS is heterozygous that we saw previously. She has a CBS C699T polymorphism, so that can affect cystathionine beta synthase ability to break down homocysteine. Could potentially be supporting glutathione or could be causing oxidative stress in an inflammatory setting, which we can tell from her history was what the case. And then she is homozygous for MTRR, so the recycling of cobalamin to methylcobalamin was significantly affected. So here we did methylcobalamin injections. We started with the hydroxy and then tried the methylcobalamin, which she did well with. We did some additional supplements I already talked about. We added the phosphatidylcholine because of the MTHFR compound heterozygous and those liver enzymes, likely estrogen dominance. And I used sunflower lecithin that's got phosphatidylserine in there, phosphatidyl and ethanolamine, a lot of other options, and some nervine herbal tincture. I don't love Xanax, so I try to use herbs when possible. So her mood, this is after 3 months, we had a significant improvement, 8 out of 27 from 12 out of 27. So she went down to mild depression, and in 3 months, I feel pretty good about that. Her diet was improved. She was really struggling. She was struggling to incorporate fruits and vegetables and water, but she was trying. She did well with the things I told her to eat. It was hard to take things out. And too many leafy greens caused her gas and diarrhea. So she did lose some weight, and she did start working with a trainer, and her fatigue was overall reduced, but too much exercise really wiped her out. And her food cravings were reduced, but she was still struggling with that habit. Her blood pressure had gone down a little bit, so we talked about reducing her blood pressure mid, and she sort of thought maybe night vision changed in the dry eyes, but she couldn't quite tell. But her labs told us her total cholesterol came down, her LDL went down, her vitamin D came into range, vitamin A was in range. We don't have anything to refer it to, and like I said, it's not the most reliable, but something good. Overall, her iron panel looked good, ferritin was okay at 22, not amazing. Her AST and her ALT came down. That was really exciting because this is something she'd been worried about for a while. And then, we continued to work together and we ended up doing some more gastrointestinal work, looking at actual function of her GI tract and working on healing things in order to optimize her health. But, I think that was a pretty good outcome. And it's, she's a fun patient to work with.